Hello, everyone. Welcome to another exciting edition of GynoScope, a unique academic collaboration between Dr. Aditya Nimbkar and SIMSOG. GynoScope is a dynamic platform dedicated to cultivating a space where emerging medical professionals can connect, engage, and deepen their expertise in obstetrics and gynecology. Our aim is to offer an enriching experience through a blend of thought provoking case studies, interactive discussions, and stimulating challenges like Dr. Nimkar's popular brain benders. We aim to foster a rich learning environment for all involved. Our case today is Antepartum Hemorrhage, presented by Mohak Agarwal and Srilekha Anand from Seth Medical College, Mumbai. We are thrilled to have you join us today for another session filled with valuable insights, collaborative exchanges, and clinical exploration. So let's get started. Over to you, Dr. Nimkar.
Hi, thank you, Harini. Mohak, Srilekha, let's begin. It's 10:30 already. So apologies for the slightly delayed commencement to the session. We'll keep the format the way it is, so the way it has always been. The case shall be read out first, and then we'll follow it up with the Viva. So Mohak, Srilekha, shall we begin?
Yes, sir.
Okay. I think your voice is getting is having a lot of phases into it. It's not great enough. Could you just get that sorted? What is
Sir,
it?
am I audible now? Hello?
Yeah, you're audible. It is just the clarity. Yeah, start.
Yes. Uh, so let's start. Our patient, a 36-year-old female with amenorrhea since 8 months and obstetric score G6, G3, P2, L2, married since 10 years, resident of Suri, housewife by occupation, educated till 12th standard, Hindu by religion, and lower middle class by socioeconomic status according to the modified Kupuskwami classification, complained of vaginal bleeding, for which she was admitted in the ANC ward 5 days ago. Her last menstrual period was on 26 November 2024. Her estimated date of delivery is on 3rd September 2025, and her gestational age is 34 weeks plus 2 days. She was apparently all right 5 days ago when, while doing her household activity in the morning, she suddenly noticed bleeding per vagina. It was painless, acute in onset, with bright red colored blood, which soaked 3 pads and was not associated with clots. It was self limiting and stopped in about 4 hours. The bleeding was not associated with abdominal pain and backache. Her hemoglobin levels were 8.5 grams per deciliter, for which she was given blood transfusion, 1 unit, and is hemodynamically stable now. There is no history of palpitation, fatigue, or breathlessness, no history of decreased fetal movements and leaking per vagina, no history of trauma, fall, heavy weight lifting, strenuous exercise, or sexual intercourse prior to bleeding, no history of increased blood pressure in pregnancy or history of prior bleeding in current pregnancy. History of present pregnancy. In the first trimester, she had 2 ANC visits. It was a spontaneous conception. She noticed a delay in her regular periods, for which she did a urine pregnancy test at 6 weeks, which was positive. Pregnancy was confirmed at 8 weeks of gestation by a dating scan. Folic acid and calcium tablets were started. Her blood group is A positive. There is no history of early morning nausea and vomiting, no history of any drug intake or radiation exposure, and no history of fever with rash or bleeding per vagina in the first trimester. Blood glucose levels checked in the first ANC visit were normal. The NT-NB scan done at 11 weeks of gestation was also normal. Rest of the first trimester was uneventful. In the second trimester, she had 3 ANC visits. Her iron folic acid tablet started at 4th month. Calcium supplementation was continued. 2 doses of TD vaccination were given at the 4th and the 5th month respectively. Perception of fetal movements were felt at 5th month. Blood glucose levels were tested and were again normal. There is no history of epigastric pain, blurring of vision, headache, decreased urine output, or swelling of feet. No history of bleeding per vagina. Her anomaly scan was done at 20 weeks, which was normal, and rest of the second trimester was uneventful. In the third trimester, she had 3 ANC visits. Fetal movements continued to be perceived 12 to 15 times a day. Iron, folic acid, and calcium tablets were continued, and the mother is compliant. There is no history of symptoms of preeclampsia, no history of leaking per vagina or pain in abdomen. Growth scan done at 8th month, in which placenta was found to be lying in the lower segment, after which she was advised to avoid sexual intercourse and lifting heavy weights or strenuous exercise, and to report immediately if bleeding occurs. There was history of bleeding per vagina, for which she is admitted now. Past obstetric history. Her first child was a male child born 2 years after marriage, 2.5 kgs by birth weight, delivered at full term by normal vaginal delivery, cried immediately after birth with no NICU stay, currently 8 years old, alive and well, immunized up to date. Antepartum, intrapartum, and postpartum period were uneventful. The second child was a female child born 6 years after marriage, 3 kgs by birth, delivered at full term by lower segment cesarean section. In view of meconium staining, cried immediately after birth with no NICU stay, alive and well, immunized up to date. She is currently having her third child now, and she used condom in between pregnancies as a contraceptive. Menstrual history, she attained menarche at 15 years of age. Her last menstrual period was on 26 November 2024. She has regular cycles with 3 to 4 days of bleeding and uses 2 to 3 pads per day, not associated with pain or passage of clots. A marital history, she is married since 10 years in a non-consanguineous marriage. Past medical history, there is no history of diabetes mellitus, hypertension, tuberculosis contact, thyroid disorders, epilepsy, or asthma. Past surgical history, no history of previous surgeries except one lower segment cesarean section done 4 years ago. There is no history of blood transfusion. Personal history, she has a normal appetite and normal bowel bladder movements with adequate sleep and denies any addiction. And family history, no history of bleeding disorders in family. The diet history was calculated by 24-hour recall method. Her total calories were 1850 calories per day, and proteins were about 47 grams per day. So, according to the required calories and proteins, the deficit was 400 kilocalories per day, and the protein deficit was 18 grams per day.
General examination. The patient was examined in adequate light and exposure with due consent and was conscious and cooperative. She was average in build, 160 centimeter height. Her pre-pregnancy weight was 54 kilograms and currently she weighs 64 kilograms, and her BMI according to her pre-pregnancy weight is 21. Vitals, the patient was afebrile. Her pulse is 80 beats per minute, measured in right radial artery in supine position. It was adequate in volume, normal in character, force, tension, and there was no radioradial or radiofemoral delay. Her blood pressure is 124 by 76 mm of Hg, measured in the right arm in supine position. Her respiratory rate is 16 cycles per minute. Grade 1 pallor was present. Icterus, clubbing, cyanosis, lymphadenopathy, edema absent. Breast examination, Tanner staging 5, along with breast engorgement seen. There was no thyroid swelling. Obstetric examination, on inspection, the abdomen was uniformly distended with central, everted, and circular umbilicus. Scar of previous lower segment cesarean section was seen on the lower abdomen. There were no dilated veins or sinuses. Cuff impulse was absent on the hernial orifices, and flank fullness was absent. Palpation, on the local temperature was not raised. Uterus is soft, non-tender, and relaxed. No scar tenderness. The fundal height was 34 inches. The symphysiofundal height is 33 centimeter, and the abdominal circumference is 102 centimeter. Leopold's maneuvers. The first fundal grip, hard globular ballotable mass was felt, which was suggestive of fetal head. Then on lateral grip, on the right side, hard, smooth, board-like resistance was felt, which was suggestive of fetal back. On left side, irregular knob-like structure was felt, suggestive of fetal limbs. In the first pelvic grip, broad, soft, irregular mass felt, suggestive of fetal buttocks.
In the second pelvic grip, the hands converged, so buttocks not engaged. Findings of third grip were confirmed. The lie was longitudinal and there is breech presentation. On auscultation, the fetal heart rate is 140 beats per minute, felt in the right spino-umbilical line above the umbilicus. On systemic examination, CVS S1, S2 heard, no murmurs or additional heart sounds heard. RS, air entry is bilaterally equal, no adventitious sounds heard. And CNS, patient is alert, conscious, and cooperative, no focal neurological deficits, higher mental functions, motor, sensory, cranial nerves normal. Summary: the patient, a 36-year-old G3P2L2, 34 weeks plus 2 days pregnant with previous lower segment cesarean section 4 years back, admitted in view of painless vaginal bleeding 5 days ago, which was bright red in color, unprovoked, and is self-limiting. On general examination, vitals are stable. Grade 1 anemia is noted. Obstetric examination infers a singleton fetus in breech presentation with fetal heart rate of 140 beats per minute. Diagnosis: the 36-year-old female G3P2L2, 34 weeks plus 2 days pregnant with complaints of bleeding per vagina is a case of antepartum hemorrhage due to placenta previa with a singleton live fetus in breech presentation and is admitted now for safe confinement of pregnancy.
Great case, Srilekha and Mohak. Could you just go on to your first slide? Okay, so given that we are talking about antepartum hemorrhage, although your case is looking a lot like placenta previa, could we just, encompass all the causes of antepartum hemorrhage? And could you tell me how are each and every factors, the demographic factors over here, responsible for causation of antepartum hemorrhage?
Okay. Sir, so antepartum hemorrhage is bleeding from or into the genital tract after the period of viability, which according to RCOG guidelines is 20 weeks. And the causes of antepartum hemorrhage are placenta previa, abruptio placenta, both of which have equal incidence, like one third, 33%, 33%. And the rest of the 33% includes vasa previa, local causes like cervical lesions, cervical cancer, ectopy, or vulvovaginal varicosities, and unexplained. Unexplained causes contribute 25% to the total.
Are
And
you sure that everything is correct? Are you sure that the fetal viability period as per RCOG is 20 weeks?
like in RCOG guidelines, it was written that antepartum hemorrhage is bleeding from or into the genital tract after 20 weeks of gestation.
Okay. Technically, if I'm to speak, antepartum hemorrhage is anything, any bleeding right from day one of your conception. So it encompasses threatened abortion as well. The
Okay.
period of viability that you equated with the definition was the only wrong part, nothing else. The period of viability stays 24 weeks. In fact, they have just gotten it down to 23 weeks now. But even below 23 weeks, they now call it peri-viable to pre-viable. So it is 23, 24 weeks. Apart from that, everything is pretty much correct. Yeah.
Okay,
So
sir.
you could you just enlist the causes of antenatal, not antepartum, antenatal hemorrhage, if I'll put it that way, right from first trimester?
Sir, in the first trimester, there can be abortion. Then there can be ectopic pregnancy, and there
Molar
can be
pregnancy.
molar pregnancy and local cervical lesions like cervical cancer or cervical ectopy. Uh, Sir, in the second trimester, also abortion and uh, molar pregnancy and ectopic
Abortion.
pregnancy, sir.
Okay, second trimester mein your classical placental causes also start coming into play because your
Yes,
placenta is formed by 12 weeks. So previa and antepartum hemorrhage because of abruptio is also going to
abortion.
come into your picture from second trimester. Okay. Could you tell me what is CAOS, chaos?
Sir, chronic abruption oligohydramnios sequence. So, sir,
Very
in
good.
chronic placental abruption, there is a lot of blood loss from the placenta, due to which there is decrease in the fetoplacental circulation and
There is
the blood
decrease.
flow to the fetus it decreases, which decreases the renal blood flow in the fetus, and hence there is oligohydramnios.
Very good.
Oliguria leading to oligohydramnios.
Correct. So basically, that chronic abruption is like that abruption that has occurred in your first or early second trimester. Abruption, basically, the vessels at that part have gotten sheared off anyway, and they are never going to recover now. So it stays that way, and that part continues malperfusing the placenta and the fetus, and hence the fetus develops oligohydramnios, and that abruption also stays the way it is. Correct answer. Great, great, very good. Okay, coming back to the demographic details, age, any relevance here?
Yes, sir. With age, sir, basically with increased maternal age, there is like a decrease in the number of follicles, and there is hence a decrease in estrogen levels, which can lead to endometrial atrophy, and the receptivity of the blastocyst to the endometrium it decreases, which causes the implantation of the blastocyst in the lower uterine segment, causing placenta previa, and
And also with increasing age, the risk of vasculopathies increase. So, like there can be atherosclerosis or in the spiral arteries, which can lead to hypoxia. In response to it, the chorionic villi spreads over a larger surface area to get nutrition, and because of that, there is a placenta previa. Placenta gets formed in the lower uterine.
And sir, after 35 years, like after the age of 35 years, the incidence of the risk of placenta previa it increases to fourfold. So yeah.
Beautiful answer, especially the endometrial hypothesis that you mentioned. Amazing answer, excellent answer. I would give that to you. Very good. Also, as your age increases, the number of episodes of PID increase, the number of possibilities of your abortions followed by dilatation and curettage increase. So basically, all these events which are going to lead to fibrosis or fibrotic segments in your endometrium, which will prevent the migration of your placenta,
Yes.
are going to increase. Yeah. So that is another cause why your chances of placenta previa increase. Okay. Your parity score is gravida 3 para 2 living 2, so multiparous female. Could you
Yes,
tell
sir.
me,
In
is that going to affect?
multiparous female, sir,
With each pregnancy, there is uterine scarring and remodeling that takes place. So, with each pregnancy, after when there is a multiparous female, because of endometrial scarring, repeated endometrial scarring, the decidual receptivity again increases. And also there is a and so the blastocyst implants in the lower uterine segment because of
Very
this.
good. Great answer. Amazing answer. Apart from that, also remember that whenever your uterus is going to contract, every time involute, not contract, involute post delivery, at that point of time, the involution is not going to be an even as an एकदम regular, homogeneous नहीं रहेगा. In some segments, it is going to be very compact. In some segments, there is going to be a bit of lax tissue, loose myometrium. So if those loose myometrial pockets are going to be mostly formed around your lower segment because that happens to be your isthmus that has stretched thin into the lower segment. So that is the point where because of that niche that is created, one gap like thing that is created जहाँ पे placenta या फिर जहाँ पे blastocyst का implantation हो सकता है. So yeah, another reason, very correct. You mentioned about migration and scarring. What is this process of migration called as?
So there is like there are two reasons for migration.
No, we
So
couldn't hear
one
you.
is trophotropism.
The voice wasn't clear. Could you repeat?
Now, sir, is it audible now?
Yeah, yeah, audible now.
There are two reasons for migration. One is trophotropism. Like the placenta migrates towards the fundus as it has more blood supply, it's more vascular. And the second is the isthmus grows in size. Like the isthmus of a non-pregnant female or isthmus at 20 weeks of gestation is only 0.5 centimeter, while at third trimester or at term, the isthmus becomes 5 centimeter in length. So this pushes away the placenta. So this differential growth, even if the placenta was earlier in the lower segment, it will later shift to the upper uterine segment.
Excellent answer yet again. Beautiful answer. Very good. Okay. Then you have mentioned about the educational status and socio-economic status. Any bearing on your history?
So our education implies like it is important if the female understands her condition and whether she is willing to like if she is able to stay compliant. It matters for that. And socioeconomic status, like in our case, it's lower middle. So it has a bearing on the kind of nutrition that she receives. So if there is poor nutrition, it would in turn lead to anemia. So there can be poor healing because of that. And also
Also, one more
residents.
thing, due to
And also,
anemia,
sir, there
because of
can be vitamin B9 deficiency when there is poor nutritional status, which can further aggravate. It is a risk factor for placental abruption, sir.
yes, very good. Also, you mentioned about anemia. Will anemia lead to something else as well?
In like it can increase the risk of postpartum
PPH, sir.
hemorrhage because
No, no, no.
it.
No, no, not about PPH. I'm just talking about placenta ka structure in general. What
Sir,
will
it will cause
anemia?
hyperplacentosis, sir.
Excellent.
Placentomegaly, which
Hyperplacentation.
can cause
Yeah,
placenta previa.
very good. So basically, it will be spread out over a larger area. Okay.
Yes.
There's someone who has asked in the comments, Srilekha, it is for you actually. Could you just re-explain the second point, the one after trophotropism?
Okay. So there are two reasons why the placenta, even if it is present in the lower uterine segment in the initial part of the pregnancy, shifts upward. Is one is trophotropism, and the second one is the isthmus. At 20 weeks of gestation is only 0.5 centimeter in size, while at term it becomes 5 centimeters. So it increases 10 times. So when it elongates or when it increases in size, the placenta will automatically be pushed upwards.
As the isthmus is becoming the lower uterine segment in the third trimester.
So, yeah, yeah, correct. I just had muted myself. Next slide. Okay. So she mentions about vaginal bleeding. You have already mentioned the causes of vaginal bleeding. Could you tell me, whenever a female is coming to you with bleeding per vaginum or vaginal bleeding, how do you characterize vaginal bleeding? What are the various headings?
Yes, sir. So, vagina, we have to ask for the characteristics of the bleeding. First of all, we have to differentiate bleeding from show because sometimes it can be confused. So, that first, and also what is the color of the bleeding? Like in abruptio placenta, it is dark colored bleed, while in placenta previa, it is bright red in color. And then we have to ask if there was any precipitating event like trauma or fall, or whether she had high BP in pregnancy because it is more associated with abruptio placenta. And also if there was pain in abdomen can also be like show. If it's with show, then it can be preterm labor, or if pain in abdomen and if it's proper bleeding, then it can be abruptio placenta. And if it is painless causeless vaginal bleeding, then it would be placenta previa.
Correct. You mentioned hypertension as a cause of abruption. Could you mention what is the pathophysiology behind that?
So when there is preeclampsia or where there is very high level of BP, it will eventually lead to endothelial injury. So it can cause rupture of the spiral arteries, and the blood will then accumulate between the decidua bissalis and the placenta, and eventually the placenta will get separated.
Excellent answer. So basically, because of excessive blood velocity as well, the shearing of spiral arterioles, the tearing of this arterioles is going to lead to accumulation of blood between the placenta and your decidua bissalis. Decidua bissalis is basically that part of decidua which is present beneath the placenta over the replacement to the endometrium. Correct. Um, could you tell me what are the various causes now that you have anyway come into abruption? Could you tell me what are the various reasons, apart from hypertension, of course, that can lead to abruption?
Sir, firstly, there is increased maternal age and increased maternal parity, which we already discussed. Then, in case of smoking, sir, the female is susceptible to various vasculopathies, which can again cause abruptio placenta, as we discussed earlier.
Smoking is a risk
Sir,
factor more so for previa or for abruptio?
So for both, in abruptio also, when there is increased age, so she will have vasculopathies, and the vasculopathies can cause rupture of the spiral arteries, and also with increased parity because of the scarring of the endometrium, there can be poor decidua, like abnormal. There can be poor decidual reaction, which can cause separation of the placenta. Then in smoking, there is release of carbon monoxide, which causes
placental hypoxia and can cause placental necrosis, which can lead to premature separation of the placenta. Then, certain vitamin B9 deficiency, there can be a problem in the DNA multiplication, when the trophoblast tries to invade the decidua basalis. So, sir, there can be improper placenta formation due to which there can be premature separation. Then, if the female she has a history of thrombophilias, it can she'll be more susceptible to bleeding and hence
Because of
placental.
formation of microthrombi in the spiral arteries, it can easily rupture. And also, if there is sudden decompression of a over distended uterus, like after delivery of the first twin in twin pregnancy, or artificial rupture of membranes in case of polyhydramnios. And apart from this, because of short cord, there would be increased traction on the placenta because of, so it can easily rupture.
And sir, then in cases of circumvallate placenta, in which the maternal side is bigger than the fetal side, sir, the margins of the maternal side are rolled up, so the placenta it doesn't like fit in properly on the uterine wall, and hence there can be a separation. And then also in cases of supine hypotension syndrome, in which the uterus, when the female she lies down. Supine in a supine position, the uterus it compresses over the IVC, and it can lead to back pressure formation on the uterine vessels and
Leading
the
to the
spiral artery,
rupture.
yeah, and leading to the rupture of the vessels, causing bleeding in the decidua basalis, leading to separation, sir. And
Very good.
Single.
and also, sir, if there is a previous
Single
history of
abruption.
placental abruption, there's a 10 to 15% chance that the next pregnancy will also have placental abruption.
Very good. Great answers. Okay, so I'm giving you a case scenario for abruption itself. You have two patients who have come to your emergency. Both have abruption. One has history of an abdominal trauma. Let's assume a road traffic accident. And the other one has severe preeclampsia or abruption. In which case is the baby at a higher or the fetus at a higher risk of demise? This is more like
Sir,
a gold medal question, given that you have answered so well until now. I literally had to think hard for this question. So yeah,
Sir, we are just guessing. We are not sure.
sir, in preeclampsia, like the
think
fetus,
wisely.
sir, in preeclampsia, the blood flow to the fetus can also be like compromised after a certain period of time when there is high BP. And sir, like, and as a preeclampsia is a case of high pregnancy in which we also do the fetal monitoring like twice weekly, sir. So the fetus might be at a higher risk in preeclampsia, sir.
Okay, any other school of thought that you would want to offer? That was an interesting one that you just answered. But anything else? There's a fundamental problem in the answer that you just gave. I will tell you what it is. It's a good thing that you mentioned. It's a good way of thinking, perspective, but then there is a very fundamental error. Yeah, I will tell you what it is. Any other perspective?
No, sir.
Okay, ठीक है. Don't worry. This is a
Sir,
question that requires a
sir,
yeah,
in
sure.
PIH, there can be placental like decrease in the uteroplacental yeah, blood flow, sir. There can be uteroplacental insufficiency, which can cause fetal distress and intrauterine death, sir.
I'll give you a hint. Is
Okay, sir.
preeclampsia a one-day event? Is it an acute event?
No,
No,
sir.
sir. So when there is trauma, like the fetus does not have time to adapt. While in preeclampsia, it is occurring like since a for at least some weeks. So the fetus or the placenta has adapted for the
Exactly.
blood,
Yes.
the uteroplacental insufficiency. While in trauma,
That,
it is all of a sudden it has no time to adapt. It happens so quickly that there is more chances of death probably.
correct. You are very much there. One more thing I would want to tell you here. Right now, in preeclampsia, everything that you have spoken, we have focused on the spiral arteriole side of things. Spiral arterioles are maternal vessels. What are fetal vessels?
So the fetal
That's the
vessels are
question.
they are in the villi, sir, the tertiary villi.
Exactly, yes, correct answer. The tertiary villi. Your villi are the main fetal vessels. जो इंटरफेस जो होता है दोनों के बीच में between the fetal villi and the spiral arterioles is where the oxygenation takes place. It's a lot like how our lungs function. Now, if you have a road traffic accident, there are going to be two areas of damage. The two areas are the junction between your decidua and your placenta, the first one, and secondly, intraplacental, or what you also call as a placental fracture. So it is not just the spiral arteriole which is getting sheared off, and of course abruption ho raha hai, but also your placental fractures are shearing off the fetal villus vessels, which is why the baby is not only getting or is not only having a cessation of blood supply or blood flow from the mother because the spiral arterioles are gone, but also it is losing its own blood because the villus vessels are being broken off. So the baby is not even getting blood, it is also losing its own blood. Plus, it was not ready for this, which is why a baby with an abdominal trauma is going to succumb much before a baby with abruption, which is also why not all abruptioplacentae with severe preeclampsia come to you with a fetal demise. A lot of them, most of them, in fact, come to you with a live heart rate. Unko hota hai, they come to you alive. You do a cesarean section to deliver them quickly so that they don't die, but yeah, they do come to you alive. Samjha?
Yes.
But yeah, great answer about the adaptation. Very good. Okay. So placental fracture being the main point here and fetal vessels. इसके बारे में भी सोचना चाहिए. Okay. Now that we are anyway in abruptio, could you tell me what are the types of abruptio placenta that we know of?
There are three varieties. There is concealed abruption, there is revealed abruption, and there is mixed. So in concealed, the placenta separates from the margins. Sorry, because in concealed, the placenta separates from the center. So the bleeding is not visible, but there is a retroplacental clot that is formed. And in revealed, the placenta separates from the edges. So the bleeding appears, like we can see the bleed. And in mixed variety, that is the most common one, like some of both. Like some bleeding is happening and some retroplacental clot is also forming. Some amount of both.
I think there's some disturbance with your voice. I'm not sure if it is on my end, but I think there's a disturbance. If audience could tell me. Yeah, and yeah, that's the correct answer. Um, is the voice okay? Just let me know in the chat. Anyway, so yeah, you're correct about it. Could you tell me what is more dangerous, revealed or yeah, the voice is not clear. You just have to, I think, adjust the network. Yeah,
Yes, sir.
so what is a bigger concern, concealed or revealed?
Sir, the concealed one is a bigger concern, sir, because the anemia or the features of maternal shock which are there, they are not proportionate to the blood loss. So blood दिखता भी नहीं है and the और shock भी हो जाता है. So sir,
Very
it
poor
is
voice
more
quality. Please do something. Your voice is cracking significantly. Please, I think there is some issue with your network. But yeah,
sir,
you
am I
can
audible
continue
now?
answering. Yeah, you're audible. You were audible. It is just that it was cracking.
Sir, is it cracking now?
Yeah, it is still cracking. Maybe you can try from Srilekha's phone. Maybe.
Just a minute.
Until then, you can continue answering until you shift.
So is it better now?
Yeah, much better. Yeah.
Yes.
Okay, continue. Which is
Sorry for
worse?
the
You
it's in the
mentioned
middle of this.
concealed is worse.
Concealed is worse because the female will not even realize that she is bleeding, and she will develop directly the symptoms of shock and this. She will develop symptoms of pallor and shock, and also with bleed behind the placenta, the uterine pressure also increases, and also there is release of thromboplastin, so it leads to uterine contractions and
And sir, the percentage of fetal
Is
mortality with the
thromboplastin
concealed,
responsible for uterine contractions?
sir, it is responsible for the pain, sir.
Is it responsible for pain? Thromboplastin is merely a coagulation factor or a coagulation initiator. It is not going to cause pain or contraction. It is something else that causes pain and contraction. What
Sir,
is it?
it is actually the uterine irritation due to the bleeding which causes contraction, sir.
Yeah, very good. So basically, the blood that percolates from
Yes.
that concealed part into the myometrium, into all the myometrium, that damages the troponin and the actin and not troponin, actin and myosin का जो complex है उसको bind नहीं होने देता है, जिसकी वजह से the uterus doesn't contract. What is this condition called as that eventually leads to atonic PPH? What is this uterine condition or this uterine look called as?
Tubular.
Cuvular uterus, sir.
Yeah, cuvular uterus. ये कुआलेरी नहीं है रे जो भी ऑडियंस ने बोला है. It is
Sir,
cuvular
so
uterus. Yeah,
basically in cuvular uterus, sir, there is a lot of bleeding, and due to pressure, there is a breach in the myometrial endometrial interface, due to which the blood it enters the myometrium and it gives a port wine color of the uterus while
Which is
inspection, sir.
patchy or diffuse.
Yes, sir.
correct. So what do you do for it? You have a patient who has delivered vaginally and she's having atonic PPH. She of course already had concealed abruptio, but she has delivered now and she's having atonic PPH. How would you proceed?
So for atonic PPH, we will, so even in a case of abrupt, in any case of antepartum hemorrhage, we will keep blood ready. So we will give her blood transfusion. We will catheterize the patient, manage her, maintain her circulation, airway, and breathing. And after that, we will give her compression sutures, B-Lynch or A-Minch O-square.
Correct. So the point here is that all your drugs, they fail to act. Your medical management fails to act because the actin and myosin complex itself is damaged because of the intervening blood. So you have to be very swift in your decision to shift her for either balloon tamponade or directly for Beeline suturing. In fact, even Beeline suturing is probably going to be ineffective and you might have to go ahead with a hysterectomy. So yeah, your medical management, of course, is important, but it may not be useful in a cuvular uterus. Okay. Uh, Coming back to abruptio placentae, uh, what is going to be a mode of delivery?
So it depends on the conditions of the both fetus and the mother. So
Very
if
good.
there is fetal distress or if there is maternal shock or if there is symptoms of DIC, then irrespective of gestational age, we have to deliver immediately by cesarean section. But if the fetus is dead, then we have to look at the maternal conditions. If the mother is stable hemodynamically, then we can do a vaginal delivery. But if the mother is in shock again, then we have to do immediate cesarean section. Or if the fetus is alive and even the mother is not in shock, hemodynamically stable, and then we will look at the period of gestation. If it is less than 34 weeks, we would try to manage it, like we will try expectant management. We will give corticosteroids. We'll wait till 34 weeks and then deliver. But if it is above 34 weeks, then we will induce labor and by vaginal delivery.
Abruptio को तू conserve करेगी. Oh, wow.
Like
That is
only if like there is it's a very rare case, like it's like an exception. Only if the bleed is very small and the mother is stable and the fetus is.
And there is reactive NST, sir.
reactive NST, and you don't see a retroplacental clot because if you are
Yes.
seeing a retroplacental clot, it is going to grow probably and it is going to separate the entire placenta eventually. Okay. You decide to go ahead with a vaginal mode of delivery. Imagine that you have a patient who is 3 centimeters dilated primigravida, who is already in DIC. You have a tonically hard uterus, 3 centimeters dilated, 40-50% effaced है patient, membranes are bulging. IUFD already लेके आई है, Spalding signs अब दिख रहा है उसमें already, मतलब old IUFD हो चुका है around 24 hours. You have been, you have a colleague who's saying कि इसका ARM artificial rupture of membranes मत कर क्योंकि IUFDs जो होते हैं with Spalding sign, those heads do not apply very well on the cervix and the dilatation process is going to be impaired. In fact, a lot of people do prefer to not do um, ARM for IUFDs. What would your opinion be? Would you do an ARM? Would you go ahead with a cesarean section? Remember, your patient is in DIC and there is an IUFD already 3 centimeters dilated.
Sir, artificial rupture of membranes, like it helps in fastening the process of delivery and also decompress the uterus because it allows the blood to come down. And also
Does
It
it allow the
reduces.
blood to come down? Is that the meaning
No,
of
sir,
Yeah,
decompression?
it actually allows the presenting part to compress the vessels, sir. Like to compress the uterus, so the bleeding it reduces, sir.
प्रेजेंटिंग पार्ट तो सर्विक्स पे फंडस पे प्लासेंटा है शायद से तो not really. So basically whenever you are doing ARM your fluid is coming out ना, so your uterus is contracting, so your myometrium के हर एक जो muscle fibers है they come closer and they prevent that the expulsion of thromboplastin into your circulation. So
okay.
basically it prevents the worsening, I would say, of your DIC which may already be there. But again, would you want to deliver a vaginally or by cesarean section?
Sir, as there is DIC immediate cesarean section.
Is a DIC cesarean section a wise thing to do? Literally, the moment you open her
Sir,
skin, she is
there,
going to start
sir, there
bleeding
will be more
torrentially.
bleeding, sir, because DIC में
Exactly.
अगर so sir will go with vaginal delivery, sir.
Exactly. You try for vaginal delivery, you will assess. Primary है, maybe she might take time, but ARM करके देख, आधा एक घंटा देखो. If she rapidly progresses, which he will eventually, already tonically contracted uterus है, then let's just go ahead with cesarean section with vaginal delivery. But if not, if you feel that non-progress में जा रही है, 3-4 के आगे बढ़ नहीं रही है, then take an immediate decision. Until then, also make sure that you are giving her enough of FFPs and cryoprecipitate so as to balance her DIC out. Okay, coming to DIC as a topic, what are the causes of DIC?
Sir, DIC, sir, can be caused by sir abruptio placenta. Then, sir, there can be septic embolism. Then, if
Septic abortion,
septic abortion and
amniotic fluid
embolism.
embolism, Apla syndrome,
And, sir, when there is a retained dead fetus for more than 4 weeks. Then, sir, in cases of
severe
acute fatty liver
preeclampsia
of
or
pregnancy
acute
and
fatty liver of pregnancy.
preeclampsia, sir. Sir, in case of HELP syndrome, which is a complication of preeclampsia, sir, there can be DIC. So, sir, in DIC,
Does help
basically the
lead to DIC or does DIC lead to help?
sir, HELP leads to DIC, sir.
Okay. Uh, so see, uh, DIC में क्या होता है? Just tell me what is exactly the meaning of these three terms: disseminated, intravascular, and coagulation.
Sir, basically, sir, all over the body there is a consumption of coagulation factors and the platelets, leading to consumptive coagulopathy, and there is, sir, causing a lot of bleeding, sir, as the
Correct.
platelets are used.
बराबर. So now there are two types of DICs. एक जो तूने बताया, consumption, wherein all the coagulation factors and the platelets are getting used up, and the other one is dilutional DIC or dilutional coagulopathy, wherein you're losing blood to PPH or APH, and hence you're losing your coagulation factor. So dilution or consumptive, two types. Now in severe preeclampsia, just severe, I'm not saying help. In severe preeclampsia, because of the endothelial dysfunction, because of all those anti-angiogenic factors, and also hypertension, all your endothelium throughout the body is going to be sheared off, and there are going to be multiple areas जहाँ पे platelet plugs बनेंगे and coagulation factors use होंगे. So that is going to be how your DIC is going to start initiating itself. Now whenever these platelet plugs with fibrin clots ये सब बनते हैं and RBCs go through them, there is
Yes.
going to be lysis, इंट्रावैस्कुलर लाइसिस और माइक्रोवैस्कुलर हिमोलिसिस भी बोलते हैं, जो होने वाला माइक्रो एंजियोपैथिक हिमोलाइसिस जिसको बोलते हैं वो होने वाला है. So your DIC initial stages are leading to your HELP syndrome. हेल्प
Yes,
में
sir.
थ्रोम्बोसाइटोपिनिया भी हो रहा है पहले से, ये भी बढ़ रहा है अपना,
Liver
hemolytic
enzymes
anemia भी हो रहा है. Yes, hemolysis, not hemolytic anemia, hemolysis हो रहा है. And of course, when all of this is obstructing the blood supply to your hepatocytes, जो बीच का जोन होता है, I think zone 3 या central zone, it leads to centrilobular hemorrhagic necrosis. So basically, because of ischemia, even your hepatocytes are going to die and they are going to start releasing out LDH and transaminases. That is how your DIC का initial stages थोड़ा थोड़ा करके help को unmask करेगा. Got it?
Yes, sir.
Okay. How do you correct DIC because of APH? What is the ratio in which you give those blood products? And what is the
S-
definition? How would you diagnose it, DIC?
Sir, basically in DIC, the fibrinogen levels they are less than 150 mg per DL. There is a decrease in platelet counts less than 1,20,000. The
Anand,
bleeding time, clotting time, APTT, and the PT, they all are elevated. Then the
कितना
fibrin,
कितना INR कितना होना चाहिए?
sir, no idea, sir.
ओके, एपीडीटी कितना होना चाहिए?
सर ऐसे एग्जैक्ट वैल्यू तो याद नहीं है
एग्जैक्ट
सर
वैल्यू
अभी।
नहीं, इट इज अ मल्टीपल, मतलब लैब के ऊपर डिपेंड करता है, बट
सर टू
1.5
टाइम्स।
2x कितना? Very close. 1.5x is enough for me to start giving her correction. 1.5x is considered enough. कुछ लोग 2 मानते हैं, but 1.5 to 2 के बीच में चलता है. So 2 is an acceptable answer. APDT 1.5 times भी गए तो हम देते हैं. इससे मेरे को याद आता है, what is the new theory of coagulation? अभी intrinsic और extrinsic नहीं follow होता है. I hope you know that. So what is the new theory of coagulation? Coagulation cascade.
सर वर्चाउस ट्रायड क्या?
Furca's stride is तो
वर्चा
very old. That is तो बहुत ही एकदम classical theory है. I'm talking about all the coagulation cascade. The intrinsic and extrinsic theory is said to be no longer valid, or the interpretation is no longer the same. Any idea
सॉरी
about?
सर, नो सर।
Okay, no problem. That is going to be a homework. I cannot explain it orally, but yeah, there is a new theory that has come in, and it finds its place in the latest version of Williams, as well as I'm pretty sure will find a place in your pathology as well, pathology and medicine. Do read that out. Okay, coming back to our topic. So, in your patient, vaginal bleeding. Okay, next slide. So, it was bright red colored, which gives the diagnosis more towards previa. What are the types of previa?
So classification.
Yeah, classification.
So earlier there are four grades, sorry, four types. So in type one, or it is earlier it was earlier considered as placenta previa, but now it is called as low-lying placenta, in which the placenta is implanted within 2 centimeters of the internal os, and it is also called as lateral placenta previa. Then type 2 is marginal placenta previa, in which the margins of the placenta cross the margins of the touch the margins of the internal os. So it's called as marginal placenta previa. Then type 3 is incomplete placenta previa, in which the placenta does not completely occlude the internal os, partially occludes the internal os. So it's called as incomplete placenta previa. And fourth is complete or central placenta previa, in which the placenta completely occludes the internal os.
Correct. Okay. Um, so what is in the, as per the older classification, what is major placenta previa?
The posterior line placenta previa is the dangerous or the major placenta previa, because it does not allow the fetal head to engage, so it cannot compress the bleeding vessels, and also it is difficult to access surgically, and also it overlies the sacral vessels, which can also bleed because of that.
Correct. What is Tolworthy sign?
So in placenta previa, placenta is in the lower uterine segment. The fetal head cannot. There is a free floating head of the fetus even at term. So if we push the fetal head, then there would be fetal distress, as it will compress the placenta previa. But once we remove it, the fetal distress like subsides. But however, it is
Deceleration.
contraindicated
Fetal
now.
deceleration. Deceleration is a better one.
Okay. Yes, sir.
Okay, fine, correct. Um, you're doing a cesarean section. What is going to be a much more dangerous proposition? A posterior placenta previa or an anterior placenta previa?
सर अ पोस्टीरियर प्लेसेंटा प्रेविया सर विल बी नो सर हाँ सर
कर ले,
पोस्टीरियर
फिफ्टी
प्लेसेंटा
फिफ्टी
प्रेविया
चांस है तेरा सही आने का आंसर. बोल दे अभी दूसरा भी.
sir posterior placenta previa will be more dangerous sir because it is hard to localize the posterior placenta previa sir as there is no landmark for localization of the same sir.
अरे बट मैं लोकलाइज करूँ ही क्यों? मुझे करना ही नहीं है लोकलाइज. मैं बेबी को निकाल दूंगा, प्लासेंटा खुद से आ
तो
जाएगा.
सर
क्या?
अगर LSCS कर रहे हैं तो सर देन एंटीरियर वाला ज्यादा रहेगा बिकॉज हम लोग लाइक वी टेक द ट्रांसवर्स इंसिजन ऑन द एंटीरियर
एग्जैक्टली.
पार्ट.
या,
There is a high chance that we will cut through
कट
the
द प्लेसेंटा
placenta,
सर.
which will cause
करेक्ट.
torrential bleed.
वेरी गुड. टॉरेंशियल ब्लीडिंग से भी ज्यादा ये है कि you're cutting through the villus vessels. So
Hmm.
basically the fetus will start losing its blood. So is there any other way that you can don't tell me a classical cesarean section, that's a horrendous thing to do. Is there any way that you can circumvent, is a better term, an anterior placenta previa while doing the cesarean section?
So in the pre-operative phase, we have to first find localize the placenta exactly, and before we take the phalansteal incision, then when we go up to the level of peritoneum. Before taking the uterine incision, we have to first look for if the placenta is visible even without taking the uterine incision, or if there is any addition between the placenta or the bladder, that indicates placenta accreta. If it is not there, then only we proceed with the uterine incision. And now that we have localized the placenta, we have to take an incision above the uh, level of the placenta, and then we'll proceed that way.
Okay. So one more thing is what a lot of people are mentioning in the comments. You push or you pull the placenta to one side and you deliver the head. So by doing that, the placenta is not going to be cut through. That is what you can do. You mentioned something about placental localization. That's a very nice point. Could you tell me where is this placental localization also used in which condition and what is the procedure called as? Again, a gold medal question.
Sir, is it triple P procedure?
Excellent answer. Very good. Tell me, what is it?
Sir, so it is done. So triple P
In
procedure is done
placenta
Akrita
acrita
spectrum
spectrum.
when the female wishes to have the fertility, like she wishes for fertility.
So
So
first we localize the placenta pre-operatively. Then the pelvic devascularization. We do pelvic devascularization basically to reduce the blood flow, and then we do
placental non-separation and myometrial
a repair.
Very good. So basically, triple P procedure is done for placenta accreta spectrum, wherein after, or rather before opening, after scrubbing, before opening the abdomen, you will be localizing the exact location. After that, when you open the abdomen, then you would do placental, your pelvic devascularization. That can also be done pre-operatively by doing internal iliac artery embolization, anterior branch, and then you just excise that myometrial part where that accreta is there. Of course, you cannot do it if it is if it is complete percreta and it is taking up the bladder as well. It is only if it is restricted to your uterus and the serosa is also spared, where you can just resect the myometrium and you can close it back. This is called as a triple P procedure. Okay. That's a good answer. That's a very good answer. Okay. So in your scenario, it is looking a lot like placenta previa. Is there any other cause of bright red bleeding in third trimester that you can have? Any other differential?
So we can have vasa previa, sir.
Correct. What is that
Uh,
bleeding of vasa previa called as? First bleeding.
sir, war. Sir,
Warning bleeding is any bleeding
warning
that occurs in previa as well.
previa.
Placenta vasa previa का exclusive को क्या बोलते हैं?
No idea, sir.
Okay, it is called as a
sentinel
Benckiser
bleeding.
hemorrhage.
The sentinel bleeding.
No, no, no. It is called as a Benckiser hemorrhage. Benckiser is the first hemorrhage that occurs in your warning hemorrhage or the torrential first hemorrhage that occurs in a patient with vasa previa. Okay.
Okay.
Vasa previa, can you deliver this patient vaginally?
No, sir. Like in vasa previa, the umbilical cord is present beneath the presenting part, just above the internal os. So if we try to do artificial rupture of membranes, or even if there is even during labor, there would be torrential bleeding, that too from the fetal vessels. So it will cause fetal distress.
Fetal distress and eventual demise, immediate
Death.
demise.
Yes, sir.
Death.
Yes, sir.
Yes.
चलो तो प्री लेबर सेक्शन करना जरूरी है रुकना नहीं है वो माइग्रेट भी नहीं होने वाला इनफैक्ट सो जस्ट डू अ सेक्शन ओके you mentioned that the hemoglobin levels are 8.5 so she has lost significant amount of blood now tell me is waiting upon for a hemoglobin drop in your CBC a good way to measure how much of blood is lost or is there a better way?
Sir, we can check for the grades of pallor, sir. Like if they increase, sir, then
Pallor
हमको
is a
पता
very
चले.
unreliable.
सर hematocrit देख सकते हैं sir. Like
Correct,
if the
correct.
hematocrit is more than 30%, it is normal. But if it falls down below 30%, sir, it is like it's not
Okay,
normal,
how
sir.
can you estimate with what is the estimation as your hematocrit drops? कितना hematocrit गिरा तो कितना ml blood गया है? Do you know the estimate?
No, sir.
Okay, so for every 3% of drop in your hematocrit from your admission level, not pre-pregnancy, admission levels, there is a loss of 500 ml. So if let's assume you do not have an on admission, तेरे पास आई ही patient ऐसे condition में है, already बहुत blood loss हो चुका है. Of course, you do not have an on admission normal वाला HB. So you just send a CBC. उसमें CBC में दिखता है hematocrit. Let's say it is 21. So let us assume that it must have been 30 earlier because 30 is what is the average pregnant female का hematocrit. So 30 से 9 से गिरा है. So 9 मतलब 3 का multiples. Hence 3 into 500, which is around 1500 ml of blood has been lost by this female. So that is how you will be able to calculate an approximate amount of blood that this female may have lost. Okay. So your female has an HB of 8.5. ठीक है. How many weeks is she? Did you mention?
34 weeks plus 2 days.
Okay, 34 weeks plus 2 days. Okay. Next slide. Okay, nothing is positive in the first trimester. NTNB scan is normal. हाँ, NTNB scan का कुछ रोल है क्या इसमें? NTNB scan and dual marker का?
Yes, sir. In placenta previa, there are increased chances of congenital anomalies, and the risk increases threefold, especially the CNS abnormalities, sir, as the brain, sir, it is more susceptible to hypoxia and huh, eh, more susceptible to hypoxia due to uteroplacental insufficiency in placenta previa. So, sir, we can come to know about anencephaly or spina bifida, sir, with NTNB scan and sir, dual markers.
Okay, fine. So there is one point that you need to know, not with dual marker really, but with quadruple marker.
Yes.
Uh, if there is an increase in your alpha fetoprotein levels, they say that there is a chance that you may have an increased chance of having placenta previa. That is one correlation that they have found. But ठीक है, it is okay. You may not know this, but yeah, alpha fetoprotein का levels being high has some correlation with increased chances of placenta previa. ठीक है. In your scenario, nothing has been seen. Everything seems to be okay. NTNB and dual marker can be helpful as the way you mentioned. Aneuploidy या फिर congenital anomaly कुछ निकला तो प्लासेंटा माइग्रेट कर नहीं पाया, बेबी बहुत बड़ा निकला इसलिए. ठीक है. नेक्स्ट स्लाइड. Iron folic acid, vaccination was done. Okay. Blurring of vision, nothing. Blurring of vision and everything you have mentioned for abruptio, for your preeclampsia. ठीक है.
Yes.
Next slide.
Yes.
Okay, so placenta was found to be lying in the lower segment and she was advised section intercourse. Okay. A question that I would want to ask you, if a couple is going to ask you regarding until how long can they have sexual activity, how long can they have coitus during pregnancy, should they have it in first place? And if they can, then until how many weeks? If not, then why?
Sir, up to 36 weeks.
36 weeks. Baap re. I'm glad I cannot imagine what you just said, but okay. Uh, let's just be a little more female friendly at this point. Anything else? You'll end up, honestly, you'll end up giving premature preterm labor to her because of the stimulation to the cervix. So ideally, they say until 22 weeks, you can have coitus, but it is better to not have it after that because it can lead to preterm labor. You wouldn't want that because वजन cervix के ऊपर से बहुत बढ़ने लगता है fetus का. So yeah, okay. Placenta previa. Imagine you are working in a PHC. You do not have ultrasound. How do you know whether it is previa or abruptio, or whether there is previa or not?
Sir, we can do a double setup examination, sir.
Yes, what is
Uh,
it?
So for double setup examination, like we have to keep all the requirements of cesarean section ready, like in case there is an immediate cesarean section required. Then after voiding her bladder, we will under general anesthesia in the lithotomy position, we will first do a per speculum examination to rule out any local causes of bleeding. But even if the local causes are present, they do not necessarily rule out placenta previa. So using the index and the middle finger, we will palpate the vaginal fornices of the female. So if it feels boggy, that means it's the placenta. So then we have to immediately proceed with the cesarean section. If we don't feel anything, then we will insert the index finger into the internal os up to 3 centimeters, and we will look for the placenta. If we do find the placenta, if we do feel the placenta, then we have to again go for immediate cesarean section. But up to 3 centimeter, we could not feel it, then we have to do induction of labor and continue with vaginal delivery. And sometimes
Okay,
blood
fine.
clots and placenta can be confused, but blood clots are friable while placenta is not. So that's how we differentiate.
Okay, correct. double setup examination. Is there any role for it in a tertiary care?
What, sir?
Is there any role for this examination, this way of examination in a tertiary care hospital?
Only
Uh,
if the USG is inconclusive, but we have a high
high suspicion
suspicion
of
of placenta
placenta
previa.
pregnancy.
Correct. Okay. It's fine. By the way, could you tell me why has that traditional and new classification been so different? What has changed?
The placenta previa one.
Yes.
Sir, like in the low-lying placenta, sir, we can also try for vaginal delivery, but in the
They felt that those four phases, those four classes were kind of pointless. Although I do not believe that. I mean, they said that low lying and marginal were doing the same thing, and partial and complete were doing the same thing. There was no different clinical value of having a different class for partial and complete, and a different class for marginal and low lying. So they decided to club marginal with low lying, and they decided to club partial and complete together because, of course, you wouldn't want to give any trial to uh, partial or complete, but you may consider a trial for lower lying, although in all practicality, you do not do it. Okay. Okay, next slide. Okay, fine. Uh, Nothing over here. Next slide. Nothing over here. Next. Okay, next. No, 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 definitely not here. Next slide. Okay, no. Okay, tell me, in your patient, in your case, when would you advise termination?
So in our case, now that she is hemodynamically stable, so we have to we have to admit her, but we have to monitor her vitals, the mother's BP, pulse, and also the fetal heart rate. We have to do bi-weekly NST, and we have to keep her blood arranged at least to packed cell volume. And if she does not have any further episodes of bleeding, then we will do an elective cesarean section at 36 weeks
36 to
Okay.
37 days.
after giving
So you would be
corticosteroids.
technically giving her a conservative management for now. What is the name of that conservative management?
Uh,
Expectant management.
McAfee and Johnson.
Johnson.
Yeah, McAfee Johnson. Could you tell me what are the various components of McAfee Johnson?
Sir, if the period of gestation is less than 34 weeks, we can give corticosteroids, a course of corticosteroids. That is, we can either give betamethasone or dexamethasone. But sir, if the period of gestation is more than 34 weeks, we can still give corticosteroids, provided that we have ruled out chorioamnionitis and the female has not had a previous course of corticosteroids. Then if the period of gestation is less than 32 weeks, we can give magnesium sulfate for neuroprotection. We give 4 grams as a loading dose and 1 gram as maintenance dose. And if the female is RH negative, has a RH negative pregnancy, we can also give anti-D immunoglobulin at 28 weeks of gestation, sir.
Okay, correct. So what is your ideal candidate ka profile for you to decide on giving this patient McAfee, and for whom will you not prefer that?
Sir,
So
so
there are two managements for placenta previa, active and expectant management. So active management has to be done if any of the following is present. That is, if there is fetal distress, or if there is maternal shock, or if the fetus has reached 37 weeks of pregnancy, or 30 with less bleeding, or 34 weeks of pregnancy with severe bleeding, and if there is any severe congenital anomalies, that the fetus is not viable. So if the fetus has anencephaly, the fetus is not viable any which ways. So there is no use of preserving the pregnancy that way. And this is for, if any one of this is present, then we have to go with active management. And expectant management, so there should be no the fetal heart rate should be normal. There should be no maternal shock. That is, the maternal vitals should be normal. The fetus should be less than 37 weeks, or the and there should be no or minor congenital anomalies can be present, but the fetus should be viable. Like, the congenital anomaly should not hinder the viability of the fetus.
Okay, correct. Now that we have discussed all about accreta and placenta previa, could you tell me a little more about placenta accreta and what leads to placenta accreta?
sir, there are three theories. Firstly, the Nitabux layer is absent in the lower uterine segment. And sir, the decidual reaction, there is improper decidual reaction, and there is
There is
hyper
defective decidua basalis, or if there is absent metabux layer, or if there is hyperinvasiveness
hyperinvasiveness of
of
the
blastocyst.
cytotrophoblast, sir. Then, sir, the
The
blastocyst,
Nitabux
it
layer,
can go inside the myometrium and it can cause a morbidly adherent placenta, sir, leading to placenta accreta, sir.
the Nitabux layer prevents it acts as a layer of fibrinoid degeneration that prevents further invasion by the blastocyst. So if it is absent, the blastocyst will invade further, causing morbidly adherent placenta.
Okay, correct. Um, could you tell me what is uterine niche in this scenario?
Sorry, sir.
Uterine niche, NICHE, or maybe something that is very close to isthmocele, something
Mm,
that can be a precursor to placenta accreta.
Sorry, sir. We don't know, sir.
Okay, no problem. So basically, whenever you do a cesarean section and you suture your uterine myometrium, there is an outpulling of that area of that endometrium, and that gap or that fine slit that you can find over there is called as the uterine niche
So,
or
sir,
urban
basically,
cesarean
it's a
niche.
previous scar of the previous
Yeah,
LSCS, right?
previous scar, but from the inner side, from the
Okay.
endometrial side.
So,
So
sir, there
basically,
the Nitabux layer will be absent, and
yeah, the Nitabux layer is going to be absent, and there is a very high chance that you're going to have a scar ectopic or even a pregnancy that has gotten implanted in that has again progressed to placenta accreta spectrum.
yes, sir.
Yeah, so if you're going to diagnose it early, you would not need to do a hysterectomy. You can just do wedge resection. You can resect that scar completely and then resuture back the uterus so that you can end up saving that you can end up saving that uterus. But for that, you will need to diagnose it very clearly. Coming to that, how do you diagnose placenta accreta? What are the various features on USG?
Sir, we see, sir, when we do USG with color Doppler, sir, firstly we see placental lakes, like there is a lot of blood,
Moth-eaten
which gives us
lakes.
a moth-eaten appearance. Then, sir,
Very
there
good.
is a loss of the bladder serosa interface. Then there is thinning of myometrium. So basically, the distance between the myometrium and the serosa, it's less than 1 millimeter.
And also there is loss of the hypoechoic decidua basalis.
And sir, there is hypervascularity between the placenta and the bladder serosa interface also.
Very good. So you will basically see vessels that are perpendicular to the surface of the uterus instead of them being running parallel to the serosa. They'll be perpendicularly going between the uterus and your bladder. Okay. Uh, when will you terminate a patient with placenta accreta?
So in this, we'll do an elective cesarean section at 34 to 35 weeks plus 6 days, and followed by we have to do a hysterectomy.
Okay. You have a patient who says that this is a first pregnancy and she doesn't wish to do uh, hysterectomy. What is your, what are your options? Assume that you cannot do a triple P procedure because it has even invaded your serosa, but it has not invaded your bladder. What would you do?
Sir, so after doing the cesarean section, we will cut the umbilical cord.
We will leave the placenta
Yes,
as it is, and we will ligate the umbilical
umbilical
cord
cord
as
close
close
to
as
the
possible
placenta.
as to the placenta. Then we will suture the hysterotomy incision, and then we will do packing with sutures or tamponade. But
Very
we
good.
after this we have to follow up with serial MRIs or USGs. But eventually, in 20% of the cases, there is a requirement of hysterectomy eventually.
Correct. So basically, you're leaving the placenta inside for autolysis and absorption. But sepsis is going to intervene mostly because the placenta is richly vascular and has a lot of nutrients in it. So bacteria are going to invade it anyway. So yeah, you call it leaving it for autolysis. And also along with MRI and UHG, you will be doing beta HCG monitoring. And a lot of people even prefer to give methotrexate, which is one way of treating it. So yes. Plus, whenever you're leaving such a vascular thing inside, whenever it gets completely absorbed, it might just leave behind complete fibrosis. So Asherman syndrome usko ho
Asherman
sakta hai.
syndrome. Yes.
Yeah,
Yes.
so it is not really a wise thing to do that autolysis thing because I don't think the fertility is going to be anyway preserved after that. Because the
Hmm.
anyway
Sir,
point of keeping the uterus was
if
fertility.
we do, sir, if we do this, so फ्यूचर में प्लेसेंटा प्रीविया का चांस बढ़ जाएगा क्या, सर? अगर
प्लासेंटा प्रीविया
माइग्रेशन
का चांस तो बढ़ेगा ही प्लस तेरा
Accreta का
जहां पे भी वो ये था अधेरेंट था वहां पे फिर से अधेरे होने का चांसेस भी बहुत ज्यादा रहेगा So you would have another chance of having placenta accreta in your subsequent pregnancy. ऑल्दो प्लासेंटा प्रीविया का चांसेस इतना नहीं बढ़ेगा क्योंकि तेरा वो पूरी तरह से एब्जॉर्ब हो गया है वहां से. सो वो एब्जॉर्ब होने की वजह से योर यूट्राइन कैविटी में जस्ट बी रेंडर्ड उतना ही इफ देर आर नो अडेशंस. अगर अडेशंस होता है तो यस डेफिनेटली तेरा प्लासेंटा नीचे इम्प्लांट करेगा एंड देयर विल बी प्रीविया. बट या देर आर चांसेस ऑफ अक्रीटा एंड प्रीविया बोथ इन देम इफ देर इज अशरमैन सिंड्रोम दैट इंटरवीन्स. बट अशरमैन अगर हो गया तो इम्प्लांटेशन फर्टिलाइजेशन ये सब वैसे भी नहीं होगा. तो ये आगे की
सर,
बातें शायद होंगी.
प्लासेंटा अक्रीटा स्पेक्ट्रम विथ प्लासेंटा प्रीविया विथ हिस्ट्री ऑफ LSCS, सर, इसका भी रिलेशन है सर, लाइक
Of
परसेंटेज
course, there
वाइज.
is. There is. Tell me, how is it? Very good. That's a good answer. That's a good thing that you have asked. Tell me.
Sir, when there is a history of one LSCS, there is a 11% chance that PAS will
Also,
be
before
there.
before before you proceed, I have one more question to add to your answer. You have to answer it anyway. The chances of bleeding are much higher in placenta previa plus accreta versus when it is there individually. Why? वो भी बता मुझे.
Sorry, sir.
The chances of intraoperative hemorrhage is much higher in a case with previa and accreta together in comparison to individual accreta or individual previa. Why? तू तेरा आंसर कंटिन्यू कर तब तक इस पे भी सोच.
Uh, so, sir, when there is history of one LSCS, the chances are that 11%. There are 11% chances that PAS and placenta previa will be there together. With two, it is 40%. With three LSCS, it is 60%, and after that, it is 67 to 70%, sir.
वेरी गुड, करेक्ट. एक नंबर आंसर बताया तूने. तूने ऐसा आंसर बताया तो मेरे को भी नहीं पता था ऑनेस्टली. ग्रेट आंसर. ओके, सो कमिंग बैक टू द
Previa,
क्वेश्चन दैट आई जस्ट आस्क्ड. थिंक
yes,
अबाउट द
sir.
एनाटॉमी.
Sir, in previa with accreta, like if it is attached to the myometrium, the chorionic villi is attached to the myometrium, so it will affect the contractility
वो
of the
तो वैसे
muscle.
भी हो रहा है, वो तो किधर भी होने दे, वो तो होगा. देयर इज समथिंग डिफरेंट इन प्रीविया प्लस अक्रीटा जो सिर्फ अक्रीटा में या सिर्फ प्रीविया में नहीं था. वो क्या है? थिंक अबाउट द एनाटॉमी. योर cervix. Your cervix, a highly richly vascular organ during pregnancy, is going to be taken up, is going to be held because of the
Um,
accreta. समझा?
hmm.
तो
Yes,
Hmm.
sir.
तेरा ऑप्शन सब टोटल हिस्टेक्टमी करने का तो उधर ही गायब हो गया. तो अगर तेरा ब्लैडर इन्वेड हो चुका है, इफ योर ब्लैडर हैज ऑलरेडी बीन इन्वेडेड बाय योर अक्रीटा and hence you are thinking of not touching the bladder and hence just doing subtotal hysterectomy, is also gone. It is gone in thin air because तेरा cervix भी taken up है placenta से. So even if you leave the cervix behind, it is going to keep bleeding. Secondly, just lateral to your cervix are your very thick इंटरनल इलियक का एंटीरियर ब्रांचेस जो जाके ऊपर यूट्राइन आर्टरी बनता है और नीचे जाके सर्वाइकल डिसेंडिंग सर्वाइकल आर्टरी बनता है. सो बेसिकली इट्स अ ह्यूज वेसल देयर जिसको उसने डायरेक्टली टेकअप कर लिया होगा. So it is going to make your operative very difficult and it is going to be a bloody mess to operate in this scenario, which is why Akrita plus Previa is a nightmare. And the nightmare is because it has taken up the cervix as well as the adjacent vasculature of uterine and descending cervical artery, which is very difficult to get hold of. In fact, this is one of those very uh, good indications for doing internal iliac anterior branch का embolization pre-operatively because वहां ही से तेरा दोनों डिसेंडिंग सर्वाइकल और एंटीरियर और ऊपर का सुपीरियर यूट्राइन आर्टरी दोनों का वैस्कुलरिटी बंद हो जाएगा. ठीक है. Could you tell me what is the logic of doing internal iliac artery ligation? बहुत लोग सिर्फ यूनिलैटरल करते हैं and yet it is effective. Why?
सर, ब्लीडिंग कम करेगा ना सर, जब
Yes,
जब सर्जरी करेंगे
bleeding
तो
कम करेगा, but
50%.
there is something more to it. Think about ligate करने के बाद में प्रेशर का क्या होगा. So basically, whenever you are doing internal iliac artery ligation, your pulse pressure of the pelvis reduces significantly. and your arterial pressure beyond that ligation becomes venous pressure. And remember, venous pressure is amenable to compression. सो टैम्पोनर तो अगर मॉप दबाएगा वहां पे कोई ब्लीडिंग ब्लीडिंग के एरिया में, द ब्लीडिंग इज गोइंग टू स्टॉप आफ्टर यू डू इंटरनल iliac artery ligation. But if you don't do that, there are going to be several bleeders that will keep on bleeding and oozing, which are not going to be amenable to compression. And the more you try to take sutures, the further it will bleed. So it converts your arterial pressure of the pelvis to venous pressure, which is amenable to compression. And hence, that is an added advantage of doing internal iliac artery ligation. समझा? So that is
Yes.
another point that you have to remember very well. Okay. All these are very higher concepts. It's absolutely fine if you don't know them. Anyway, since you have answered so well, I would want to ask you one more question. How do you reach out to the internal iliac artery?
Uh, Sir, we start from the femoral artery.
Femoral?
Uh,
Bapre. Okay, femoral. पैर से.
Femoral से external
No, I'm
iliac.
not talking about your embolization का procedure. I'm talking about internal, intraoperatively.
अच्छा.
Embolization तो बराबर बता रहा है, सेल्डिंगर टेक्निक. करेक्ट है.
हाँ सर,
वो
सेल्डिंगर
मुझे नहीं
वाला.
जानना. मैं इंट्राऑपरेटिवली पूछ रहा हूँ.
सर, इंटरनल इलियाक आर्टरी का ब्रांच यूट्राइन आर्टरी रहेगा, तो
हाँ, तो
उसके मतलब
पहुंचेगा कैसे? तेरा
बैक
इंटरनल
ट्रेस
इलियाक इज
कर
रेट्रोपेरिटोनियल.
बैक ट्रेस करके सर पहुंच सकते हैं.
Back trace, very difficult. How do you
So
go into
from
the
the iliac
retroperitoneum? What is your
arteries,
window?
सर, वी कैन लाइक यूरेटर को, लाइक वी कैन टेक हेल्प ऑफ द यूरेटर सर.
बाप रे. Wow. Love your
मतलब
answer.
यूरेटर और
Very-
यूट्राइन आर्टरी रहेगा. सर नहीं पता सर.
Think about it. Which is that thing that connects you to the retroperitoneum? Which ligament? A big hint for you. Deep ring, superficial ring. Inguinal rings. कौन सा निकलता है inguinal ring में से? Ligament.
सर, ब्रॉड लिगामेंट, राउंड लिगामेंट एंड ब्रॉड लिगामेंट सर.
Exactly, round ligament. Round
हाँ सर.
ligament is the one that escapes through your deep inguinal ring and comes out through your superficial inguinal ring. And
यस सर.
whenever you divide or whenever you just cut your round ligament, which is anyway a useless ligament, you also open up the broad ligament. And the moment your broad ligament is opened up, you get your way to the retroperitoneum. And that is how you also go to the ureter to check if there is any injury. That is also how you go to the internal iliac. What is the problem if you do not ligate the anterior branch and you just ligate the internal iliac?
सर, द इंटरनल आइलियाक इट
the
ऑल्सो,
femoral pulse.
नहीं, femoral external से सर. इंटरनल आइलियाक इट ऑल्सो सप्लाइज अदर स्ट्रक्चर्स लाइक द यूरेटर एंड द वजाइना
सही.
सर. सो वो भी कॉम्प्रोमाइज हो
बहुत ही
जाएंगे सर.
ऑब्वियस क्वेश्चन मैंने पूछा है. अगर एंटीरियर को छोड़ के तो सिर्फ इंटरनल इलियाक को करेगा तो क्या होगा? बहुत ही ऑब्वियस सा आंसर है इसका. कौन सा ब्रांच ब्लॉक हो जाएगा जो नहीं करना है?
सर, सर यूट्राइन आर्टरी भी ब्लॉक हो जाएगा एंड
तेरे
पता नहीं.
एंटीरियर के 6-7 ब्रांचेस है,
हाँ सर.
लेकिन तेरे को एंटीरियर छोड़ के तूने पूरा इंटरनल इलियाक को उड़ा दिया. अरे तेरा पोस्टीरियर ब्रांच भी तो चला जाएगा.
सर सर, सर वो सेक्रल वेसल्स वगैरह भी चले जाएंगे सर. पोस्टीरियर
हाँ,
सेक्रल
तेरा ग्लूटियल वेसल्स, तेरे को पूरा
वेसल्स.
ग्लूटियल पैच आएगा बिना सेंसेशन का, चला जाएगा. वो बैठेगा इंसान को फिर भी समझा नहीं आएगा कि वो बैठा है. नेक्रोसिस होगा तेरे बटक्स के रीजन में नीचे. So your posterior gluteal vessels are going to be affected because of that. And if you're a very pathetic surgeon, then you would not be able to know which is internal and external, and you will end up ligating external. Let's
सर
let's
फिर तो
just
लोअर
let
लिम्ब
me
कॉम्प्रोमाइज हो जाएगा सर.
Femoral
pura
pulse.
lower limb compromise. Let me just tell you a scenario. I'm not going to mention which patient, which specifics, which hospital, but in one of the hospitals that I've worked at, and I've worked at only 2 hospitals, there was intervention radio ने किया था uterine artery embolization. Uterine artery embolization किया था. Unfortunately, because of some procedure related complication, the external iliac artery was damaged at its junction with the internal, and that led to a continuous thrombus formation वहां पे, and that thrombus led to the female having दोनों साइड पे गोची हो गया. तो दैट लेड टू उनका जो बलून होता है वो फूट गया, उसका डैमेज हो गया था. दैट लेड टू द फीमेल who was supposed to undergo obstetric hysterectomy for placenta accreta. ये तो हो गया, but 10 days later she lost both her limbs right from her hip joint downwards. So she had to go home without her lower limbs. So that is the complication that can arise by poor technique or faulty technique, which is why to learn the art of intraoperative internal ilia category anterior branch ligation is very important, so that you're only specifically ligating those branches that are supplying your pelvis and nothing outside of that. Imagine coming to the hospital, walking for your accreta and going home literally without any lower limbs. So that is why you need to know the anatomy.
Yes,
Fine.
sir.
So I think we have answered everything and you have attempted all the PG questions really well. Very impressive. Srilekha, Mohak, pretty good. Loved your session tonight. And I think Mohak, you are the one who जो मैं second year में I think session लिया था इसके class में सिखाया था तभी तू I think मेरे से बात करने आया था. I think you had gotten your number तभी 1-2 साल
Yes,
पहले.
sir.
Yeah,
Sir, third year,
great.
sir.
Yeah, third year. Yes, correct. So great, great bit of answering and loved your answering today. So I hope that was a good session. Everything you have answered everything very well. मैं तो अक्रीटा डीआईसी में भी घुस गया था जो मैंने बताया नहीं था घुसूंगा. So pretty good. Um, Tara is asking, could you tell me the source from to read APH? Srilekha and Mohak, you have answered it so well. I would want to give you the privilege of guiding the students. What were your sources?
Sir, firstly we did Sharmila Babu and Datta. Then sir Green Top guidelines पढ़े थे sir RCOG के वो and
Marrow.
and Marrow से एक बार किया था sir मतलब
Pretty
starting
good.
में.
Very good. Great answer. ये भी एक अच्छा आंसर दिया. Good. मैरो को लास्ट बताया. गुड बट या सो ग्रीन टॉप गाइडलाइन बहुत अच्छा है एंटीपार्टम हेमरेज का प्लासेंटा प्रीविया एंड अक्रीटा का वो डेफिनेटली सब लोग एक बार पढ़ो एंड इट इज वेरी गुड उसमें सब मस्त दिया हुआ है सो यस प्रीटी गुड गाइडलाइन सो यस दैट्स इट फॉर टुनाइट थैंक यू सो मच मोहक थैंक यू सो मच श्रीलेखा
Sir,
अमेजिंग आई
sir,
फाइंड
I just have a question, sir. Sir,
बोलना
could you please just tell us about anesthesia मतलब कैसे अप्रोच रहेगा इसमें लाइक एपीएच में कौन सा एनेस्थीसिया यूज करेंगे ड्यूरिंग सी
मस्त
सेक्शन?
आंसर तूने पूछा अभी सुन सो दैट्स अ गुड क्वेश्चन अपने पास दो मोडालिटीज है आई विल टॉक अबाउट अगले 10 मिनट में लेबर एनाल्जेसिया एज वेल पहले तेरा क्वेश्चन आंसर करता हूँ इफ द स्टूडेंट्स वांट आई विल आल्सो टॉक अबाउट लेबर एनाल्जेसिया जस्ट लेट मी नो इन द कमेंट्स इफ यू ऑल वांट टू लर्न अबाउट लेबर एनाल्जेसिया इन 10 मिनट्स इन योर सिनेरियो सबसे पहली बात याद रख दैट योर पेशेंट हैज लॉस्ट ब्लड ऑफ कोर्स यू आर रिप्लेनिशिंग इट एंड राइट नाउ योर पेशेंट सीम्स टू बी क्या बोलता हूँ उसको योर पेशेंट सीम्स टू बी hemodynamically stable. So if I have to do an emergency LSAS right now, assuming she is 37 weeks, right now अगर करना है, I will go ahead with regional anesthesia and not general because she is hemodynamically stable. But if she wouldn't have been hemodynamically stable, then I would have not gone for regional, that is spinal, because spinal से sympatholysis होता है. Sympatholysis से तेरा सिंपैथेटिक ड्राइव कम होता है एंड देयर इज ट्रांजिएंट हाइपोटेंशन उसके वजह से होता है ट्रांजिएंट टैकीकार्डिया रिफ्लेक्स टैकीकार्डिया दिस इज बेसिकली इंक्रीजिंग योर कार्डियक लोड इवन फर्दर ऑलरेडी ब्लड लॉस की वजह से बड़ा है इट कैन इंक्रीज इट इवन फर्दर which is why I would want to prefer general anesthesia only if your patient is not hemodynamically stable. Otherwise, in your scenario, I will go ahead with spinal anesthesia only. इफ योर पेशेंट वुड हैव हैड अक्रीटा दो अक्रीटा में इंट्रा ऑपरेटिव ब्लड लॉस बहुत होने वाला है प्लस द ऑपरेटिव टाइम कैन गो अप टू 4 hours 5 hours मोर सो इफ देयर इज ब्लैडर रिपेयर इंजरी वो सब इन्वॉल्व इन दैट सिनेरियो जनरल एनेस्थीसिया इज ऑलवेज गोइंग टू बी बेटर क्योंकि स्पाइनल का एक सेट टाइम होता है यू कैनॉट कीप ऑन जस्ट गिविंग स्पाइनल hence general anesthesia can be prolonged for as long as you want plus you can control the hemodynamics way better with general anesthesia so in that scenario where I expect a lot of blood loss in akrita I would definitely want to go ahead with general anesthesia. प्रीविया में यस आई डू सस्पेक्ट एक्सपेक्ट ब्लड लॉस बट आजकल के जितने स्किल्ड लोग करते हैं 1 लीटर से ज्यादा तो कभी होता नहीं है वो बहुत ही पुअर हैंडलिंग कुछ किया तो होगा सो स्पाइनल एनेस्थीसिया में उतना बॉडी टॉलरेट कर लेगा ब्लड लॉस ठीक है
Yes, sir.
Yes, sir.
ओके सो टॉकिंग अबाउट लेबर एनाल्जेसिया वेरी क्विक थिंग लेबर एनाल्जेसिया में अपने पास बहुत सारे तरीके होते हैं बहुत सारे तरीकों में आते हैं नॉन इन्वेजिव एंड इन्वेजिव नॉन इन्वेजिव में वी हैव नाउडेज स्टार्टेड गेटिंग ट्रांसडर्मल जो ये रहते हैं स्टिमुलेशन के जो पैचेस मिलते हैं तो बेसिकली इलेक्ट्रिकल नर्वस स्टिमुलेशन के पैचेस दोज आर बेसिकली बैंड्स दैट यू स्टिक टू योर एब्डोमेन नाउ दोज आर थिंग्स दैट यू मस्ट हैव सीन इन फिजियोथेरेपी फॉर नी पेन जॉइंट पेन तो फिजियोथेरेपी वाले वो देते हैं टू रिड्यूस द पेन It is basically based on your gating therapy, gating theory. Gating theory is basically एक nerves को stimulate करोगे तो दूसरा nerve का जो pain है वो कम होगा. तो similarly nowadays you are getting those TENS वाले बैंड्स मिलते हैं जो नॉन इन्वेजिव वे में तुम लोग एब्डोमेन पे एक एब्डोमिनल बाइंडर जैसे, एक एब्डोमिनल क्या बोलूंगा, गार्ड जैसे प्लेस करते हो, एंड इट हेल्प्स इन योर लेबर एनाल्जेसिया. It is an okay way of controlling your pain. Invasive method में you have parenteral method. Parenteral मतलब intravenous तुम लोग दे सकते हो पैरासिटामोल, कुछ लोग ट्रामेडोल देते हैं, which I am not something that I approve of, क्योंकि वो ओपियोइड है एंड बेबी को ओपियोइड विड्रॉल आ सकता है डिलीवरी के बाद. Or you can just occasionally give diclofenac, not in large quantities because again premature closure हो सकता है ductus arteriosus का fetus में. अपार्ट फ्रॉम दैट पैरेंटल से अगर कंट्रोल नहीं हुआ तो उससे एक हायर लेवल है एपिड्यूरल एनाल्जेसिया, द बेस्ट फॉर्म ऑफ एनाल्जेसिया फॉर लेबर. एपिड्यूरल एनाल्जेसिया इतना अच्छा है कि उससे हाइपोटेंशन भी नहीं होता है. द ओनली थिंग इज यू नीड अ कंटिन्यूस मॉनिटर टू मॉनिटर हर. टॉप अप देते रहोगे, इट इज गोइंग टू बी अ वेरी पेन फ्री प्रोसीजर दैट यू कैन गो अहेड विद. उसके बाद में आता है स्पाइनल एनाल्जेसिया. स्पाइनल इज व्हाट यू गिव फॉर ऑल योर एलएसीएस. उसमें you have a set time, you have to do your cesarean section within 1.5 hours, plus your drugs are a lot dependent on your body metabolics. So if your patient is having hyperthyroidism, if she is obese, ये सब जो factors है, या फिर your patient, your atmosphere in the operation theater is very cold, and because of that shivering the patient is going to quickly metabolize those drugs, and your spinal time can get shortened to as short as 30 to 45 minutes. So you have to be quick with your surgery. So spinal time will always have that finite amount of time in which you have to operate, but it is swift. It is very good क्योंकि your patient is conscious and aspiration ये सबके भी chances थोड़े कम होते हैं. Next, you have general anesthesia, which you do for prolonged surgeries and wherever you want or wherever you expect there is going to be prolonged surgery, excessive blood loss, and काफी blood loss. ये सब अच्छे से manage करने के लिए you would require intubation as well. And post-operatively, because the patient, until the patient stabilizes, you would want to monitor the patient's hemodynamics and ventilation and everything. इसलिए patient को general anesthesia में उसमें करते हैं, so as to be able to manage your hemodynamics better. So these are all your modalities that you can use for labor analgesia as well as cesarean anesthesia. That's it. So with this, we end the session tonight. It's already past 12. This was our 11th session. So thank you so much, Srilekha. Thank you so much, Mohak. It was great having you both. Very well done. Thank you so
Thank you
much,
so much,
everyone.
sir.
Yeah, thank you. And there's a feedback form that we have put in the comments. I think there's not yet put. We'll send it on the group. So thank you so much, and we'll see you again for the last session on Saturday. Thank you.